Alors, c'est un plaisir d'accueillir.
It is with great pleasure that I welcome Madame Paula Campana. She is a leading figure for physiotherapy in Quebec. She is here to answer the question, exercise, a good pill for Parkinson's. Paula Campana is a physiotherapist and assistant of physiotherapy at the Geriatric Institute of Montreal. She is responsible for clinical teaching at the Rehabilitation Institute of the University of Montreal. She has been for the last 30 years involved in geriatrics, and since 2000 she gives trainings specifically on Parkinson's disease and other Parkinson's syndromes to physiotherapists, occupational therapists, and other professionals in healthcare in Quebec. After the presentation from Madame Campana, there will be a Q&A period like we did this morning, so please reserve your questions for the end. Put your hand up. We'll bring you a microphone. So please join me in welcoming Madame Paula Campana. Hello, everybody, and thank you for this wonderful invitation. I am very happy to be here with you because I have been teaching this stuff for many years, and I am happy in speaking with people who are directly concerned with these issues. So I'm just going to give you some of my experience, and I'm going to do an overview of this literature that I've been working with for a long time and with people who have Parkinson's. So I'm here to share all of this with you today. So I'm just going to do an overview because you already know about this stuff, and we already talked about the illness this morning. So I'm going to give you my point of view with regards to movement and exercise and not medication. So Parkinson's disease is an illness of movement. Movement is affected visibly and in an important way. So the motricity of the body are controlled by a chemical called dopamine. That is the agent that is the first actor in organizing movement. Dopamine transmits the signal between the brains and the nerve endings that are in the muscles and that give rise to movement. So when cells that produce this dopamine die following Parkinson's, there's an impact on the capacity of movement, and the symptoms are progressive. So Parkinson's disease allows for a long life. It is not an illness that affects the length of life. It is the quality of life that is affected. And the progression is different for each person. Not everybody progresses in the same way and at the same time. So when the doctor, because now we know a lot more of the details, not just motricity problems, but other non-motricity problems that can happen with this illness. So neurologists do a diagnosis as soon as trouble moving appears. When the person starts to be less able to move, then we diagnose Parkinson's if the symptoms are present. But we know that this dopamine, this substance, is already degraded down to about 20%. And so when we see problems with movement, so this is a sickness that evolves slowly for about 10 years before we see the onset of the first symptoms. So there are signs if you we already talked about this, but there's a loss of smell and taste without any other apparent reasons, sleep problems, REM sleep problems, agitation during sleep, vision problems, constipation. These are signs that can be confused with other illnesses or just with normal aging. So we don't go to a neurologist because we are constipated or we have nightmares or we're agitated at night, but symptoms evolve, progress slowly with time. We also saw where Parkinson is located, It is in what we call the basal ganglia that are involved in controlling automatic movements. And so, to understand how to improve movements, we have to find out where the problem is. And it is in the basal ganglia that initiate movement. So, when somebody tells you, especially asks you to stand up, for example, if nothing happens or it's difficult, it is because the basal ganglia in these specific sites of the brain, dopamine does not go get there and does not transmit the command or the information. We say to the person, stand up, the person tries and cannot. It is because the message is not relayed. That is what the basal ganglia does. The other role is regulation and starting and stopping movement. It's just as difficult in stopping a movement than starting it. Sometimes somebody is walking and they have to stop and they can't right away. The movement continues again for a few seconds, and so that also is the role of this basal ganglia. So if we understand these functions, the initiation and interruption and changes in movement appear in those who are struck with this illness. And so the same way to give the same command by another voice, a voice that is not somebody who's not struck by the malady, there's the illness, the movement will appear normal. So this is also for the basal ganglia, help us to prepare and maintain other functions. And so when you say, we'll go open the door of the house, we already know what the intensity of the handle is, how we have to move, how fast we have to pull the door or push the door. So it's a schematic that is already there in our brain. And normally, if we open the door, we open it without thinking and we just go outside and that's it. And so when we have Parkinson's, all these automatic movements are affected by the pathology. So we don't have this capacity of saying, I walk to the door, I reach out my hand, I turn the handle, and so with the right intensity. So what happens is the brain will be confused. We don't have to walk, we have to stop by the door, we have to grab the handle and turn it. These are too many commands at the same time for somebody who has this pathology. So there's some blockages there. So instead of having fluid movements are staccato, and we have to stop and start the movement again. So what are the consequences of this loss of dopamine? It is especially all activities that we say are automatic movements. Everything we do without thinking is affected by the illness. So eating, speaking, writing, walking, writing, do two things at the same time as well becomes something that is not as automatic, not as fluid. You have to stop and think about things before doing them, whereas you could do them in a fluid way before. So all these activities that you usually do automatically, once you have Parkinson's, they demand an extra mental effort and extra concentration, and that makes the person very tired because they have a lot to do in a day, and life is already complex enough as it is. And so through time, having them do two things at the same time becomes difficult. Walking and talking, for example, becomes difficult. To avoid falls or problems, you could only do one thing at a time. And for us who work with people stricken with Parkinson's, we cannot walk with them and talk with them at the same time. How are you today? You can only do one thing at a time. So the effort and the tiredness comes from the conscious thinking of every movement before we move. And that's what we're going to see now. So a little bit of an illustration of the classification from the point of view of motricity, of movement, ability to move. So we have stage 1, where there is some symptoms, Stage 2 is when the illness goes to the other side. It's not asymmetrical. If there's some shakes on the right, after a certain time they can appear on the left side of the body. And in any case, the person cannot keep full autonomy after that point for too long. Stage 3 is when there's balance and walking issues, and that's what brings people to have to be hospitalized to adjust their medication to get them back. And stage 4 is when walking and balance is very compromised. That's where you have to use aids like canes and things, and mobility is really compromised. The person can still walk and move a little bit, but needs somebody's help. So cannot be fully autonomous. That is when patients can be hospitalized for longer periods in long-term care. So you already know this probably, but a person who has Parkinson's is an illness that is not predictable, even though we know about the progression, but the progression is not the same for everybody. So from one day to the next, the way the illness presents can be different. So it requires constant adaptation, a constant evolution of our reaction to the illness, and through research or physiotherapy-wise, or all these efforts that we expend, and we cannot find a way to halt the illness. We can slow it down, improve the quality of life and how we cope with it, but you cannot completely stop the evolution of this illness. Not yet, anyway. So the symptoms, we've already seen them this morning: tremors, rigidity, akinesia, bradykinesia, postural instability. Those are the classic symptoms. We also have neuromotor symptoms that are frequent, much more important in number than motor issues. And through time, at the time, we didn't accord enough importance, and we do now. So hypotension, hypertension, sweating, loss of smell, problems with the bladder, problems with cognition, all kinds of symptoms that are more troublesome. And these symptoms, non-motor symptoms, can be more troublesome than the motricity ones, because studies have shown, especially the first 5 or 6 years, people suffering from Parkinson's complain more about these symptoms than tremors or rigidity that are not so severe yet. So we have to consider that, and we also try to find solutions. So unfortunately, there are complications, the motor complications that are added to that. There is a loss of mobility. So if we don't do exercise, the rigidity that is part of the illness stops us from having the range of movements. So there's the amplitude of movements that is lost. The joints are affected, and movements that we don't do every day. So hyperextension of the arms, for example, to reach for something, it's not something we do every day. So these are things that become lost. So if we don't do that, it becomes rigid and we lose those movements, and with the years there are complications. So the fact that we move less impacts not only the quality of movement, but also the joints and muscles and capacity for having a range of movements. There can be deformations and contractions also. We know that the illness is present more on one side of the body than the other. There's always one side of the body that starts that causes more problems than the other, and it can have some contractions and back pain as a result of that. So also the fluctuation due to medication, so levodopa-related fluctuations and complications that present as well. So the task is definitely an arduous one. So what do we do to treat the disease, well, medication. We all know very well about medication, but medication is essential throughout the course of treatment. There's nothing better that we have found that can replace the medication, and people must never stop or change medications abruptly. If you have to stop medication for surgery or something, usually you're hospitalized to come down from the medication. You cannot stop it abruptly. It can cause problems. So other things that we do is deep electrical stimulation. So important. This is an important discovery. Deep brain stimulation, that is a promising therapy because the technique is been perfected. The surgery has been perfected. There is technology now that allows us to better see inside the brain, so to stimulate precise areas. Or 10, 20 years ago, we didn't have the technology to do that. It was difficult. It was just the capacity of the surgeon that would allow us to find the zone that we want to stimulate. So this deep brain stimulation is introduction of electrodes into the basal ganglia that are affected by the pathology. We send an electrical charge. There's like a little pacemaker that is implanted under the skin that neurologists adjust, that provides the stimulation in the brain. So it allows us to reduce medication. It decreases the dosage of the medication or a break from the medication for a while. Then this medication can produce secondary effects. So it's promising. We will see where that goes. For now, it is not very present. I have contact with people who are over 80. There are not many at that age who have received that treatment in the past. So I think maybe now it will be more present and will improve with time. So now let's talk about exercise. So does exercise help slow down the disease? Obviously, with my experience, given that I'm a physiotherapist, of course I will say that exercise is beneficial, but that is not enough to tell people to do exercise only. There has to be research that supports this position. So does research support the fact that exercise is good for Parkinson's disease? Can we slow down the progression of the disease? Can we be in a better shape for longer? Logically, we would say yes, but it remains to be proven. So the question also is what exercises we should do and where to start. So I will just try to give you some general idea. I can't give you all the answers. There's still research to be done, but so exercise is very fashionable, if we can say that. We encourage everybody to exercise. So there are definite benefits that are inherent to exercise for everybody. So you can improve flexibility, you can improve articulations. In Parkinson's disease, these articulations that we don't use every day at hyperextend sometimes to reach stuff, for example, become rigid because we don't use them all the time. So you don't use it, you lose it, as we say. So articulations, joint movements, and to keep all the joints in good shape, to be able to have a range of movement, or at least being able to be comfortable moving. And when the medication allows us to move, the articulation, the joints will be ready to do their work. Keeping your strength up. For Parkinson's disease, that is very important to keep your strength because it allows us to compensate with balance problems. So if, for example, we are not as quick to get our balance back, at least we have the strength to grab onto something. Balance, you have to practice that to maintain a good balance. Quality of life, we feel better when we exercise. Blood circulation improves. And also specific to this illness, exercise reduces rigidity, allows us to be more flexible and have a better range of movement. So, Exercise. If we talk about the pill that we can take called exercise, it produces plenty of beneficial effects and not very many negatives. There's not much that is better than exercise, in my opinion. Improves cognition. In our research, it also shows that doing exercise even at an advanced age, even if you're not in shape anymore, allows you to improve cognitive function. So exercise must be intensive. The exercise or where the heart is working and we are sweating a little bit. So it's good for osteoporosis. The impact of the exercise allows us to keep the density, the bone density at a better level. Cardiac problems also, exercise has a big impact on that. For depression, also moving and doing exercise will increase the secretion of chemicals and hormones that help with depression, better sleep, less constipation, less fatigue. So it is a magic pill, if you will. Magic pills are very rare, and it is very, very rare that we will tell somebody not to exercise. That's not frequent at all. So I'm going to talk about what exercises are recommended, and this is depending on the stage of the illness. When you start and until the illness is more advanced, ideally it would be to start as even before illness appears, but as soon as there's a diagnosis of Parkinson's, you have to start exercising quickly, because that is when we still have all the capacities to be able to work at an intensity that will help. So start as quickly as possible and as intensely as possible, and then we can adapt depending on where we're at. And so, beginning of the outset of the illness, there are some exercises that are more recommended than others. Why? Because certain types of exercise will prevent the loss due to the illness. If we know that the illness makes you more rigid or there's difficulty in doing certain movements, if we practice those movements before the difficulties come, you give yourself the capacity, it'll be more difficult to lose these capacities.
So what kind of exercise are we talking about? Those activities do involve complex movements, where not only, let's give you an example, just raise your arm in a position, a balance position, whenever you extend your arms or your leg at the same time. So those are more complex activities for the brain and the balance, but which give you package of experience that will be very useful whenever the disease will get into this part of the brain. For instance, Tai Chi, we know that those are sequences of movements that are quite complex. So they require some time to learn them, but they really help you extend, improve your strength, your balance quite a lot. So those are the kind of exercises that really the sequence becomes more difficult whenever you have the disease. So, but you're more able than somebody doesn't do anything this kind of exercise. So boxing, obviously, there is some things here around. So the quality of boxing is that it can help you have very rapid selection and sequences of movements, not only with the arms but also with the legs. So you are in a balanced position while you move your arms, you hit. You have to move very fast, and it's perfect in order for you to face the disease of Parkinson, because Parkinson will require exactly the same thing. You have to use different arms, change from one movement to the other very fast. So that's what's really required in order to move around. And I've seen that in Parkinson conferences, people had a hard time in walking, and they would receive boxing training. They would go to the ring with very red, flashy equipment, and you'd see the person really change completely thanks to the boxing sessions. So it's very good exercise. The forward lunges and agility exercises, that's really doing extreme movements, so movements that really stretch your joints, and they help you start walking, stepping very large, change direction. So everything becomes more and more complex over time. So as long as you do train a lot from the onset, you will be able to keep doing it later on. So you really have to start whenever you are still in shape, and you can still do that whenever you have had Parkinson for the past 10, 15, or 20 years. It may be hard to start, but if you do that from the onset, it will be helpful. And then aerobic exercises. So they help you consume oxygen and help exercise the heart. So this finding comes from the past 15 years. Some researchers trained some Parkinsonian mouses, and they found out that the mouses that were training a lot, not only the disease actually would stop, but they would slow down. So it was quite a finding. Really, the searchers wanted to look more what was as to the impact of the exercise. So for the people with Parkinson's, what do we ask them to do? Well, keep doing sports and the activities you like, even increase the pace or start again. For instance, for somebody who has Parkinson's, it's easier almost to do something, to start something new, as compared to doing something that he's been doing for quite a time. Because pathology of Parkinson really has an impact on automatic things. If you do something that is not automatic, it's easier to do the exercise. The brain can work almost normally. So, if you decide that you're not going to dance because you've never been able to do that in the past, you'll be able to do it. You can do whatever you want, stationary bicycle, walking, whatever. The more intensive you can, the better. And if you are unable to go out because you're too imbalanced, going up the stairs, if you've tried that, it's easier to do when you have Parkinson than walking along a straight line. You can go up and down the stairs as often as you want. It's not really an issue. It really helps exercise your heart and your respiratory rhythm. Swimming is also very good because it's a complete sport. Not only your arms, but also your legs are moving. You require some coordination. Dancing also. In the coming center, we have a dancing group. It really helps because you listen to the music. The music helps you start dancing in a normal fashion. The fact that you have a partner to dance is also helpful because you are being trained and you have to follow the partner. So it's easier for somebody who has Parkinson just to dance with somebody instead of not doing anything because you don't have the music. Now, how much do you have to do? So the information I'm going to give you are the findings, research findings. It's not direct experience. It's rather according to the researchers how much exercising we have to do to keep those capacities. So if you are at stage 1 or 2, so at the onset of the disease, high intensity program is very important because it has an impact on your brain. So it really improves the brain functions, which is what is required. You also have to vary with more intensive sessions. For instance, you can say, I do regular exercise, but sometimes maybe I can give a boost and I will increase the pace to maximize my capacities. So minimum frequency of 3 times a week for at least 6 or to 8 weeks. You do not have to stop after 6 or 8 weeks, but if you can at least do such cycles, improvements really will keep on further to the cycles. And sometimes 2 or 3 times a year, also do intensive sessions in order to really improve what you've learned and to keep what you've learned, to remember that. However, should the disease be at stage 2, 3, or 4, obviously, you can no longer exercise as much. You do not have the capacity anymore. However, you have to look for other targets. You have to improve your flexibility, the strength of your legs. It's very important. Also, the cardiovascular conditioning, depending obviously on your capacities. Improve your balance, walk a lot more, etc. For instance, as for flexibility, once or 3 times a week for a minimum of 6 to 12 weeks, you really help exercise the whole body for, so as I said, 6 to 12 weeks as much as possible. Cardiovascular conditioning, once again, it's exercising to improve your heart, then the muscle strengthening. So 2 to 3 times a week for a minimum of 6 weeks. And 1 to 3 series of each exercise with resistance equivalent to 8 to 10 repetitions maximum. So which are the best exercises? As we mentioned, the exercises may have an impact on the disease, especially at the onset of the disease. So they can really reduce your capacities. Whatever is good for the heart is also good. It can be treadmill, bicycle, whether a stationary bicycle or bicycle on the street. The brand new things, virtual reality, for instance. In other words, play games on the computer. I'm going to show you a few examples later on. But also, like, you can run your bike in front of a screen. Strength training with a coach. I'll explain to you what I mean with this, and boxing. So treadmill, for instance. I'm showing you some findings, research findings, that 9 patients with an MP stage 1.5 to 3. So the walking was compromised and exercise too. They worked 30 minutes 4 times a week for 6 weeks, those patients. So you have some different parameters as to the speed. Further to after 1 week you increase, and then after 3 weeks you may go to 100% of the speed, and then you gradually increase the speed. So the findings, we observed a significant improvement. It means it's true improvement. The improvement is not hazardous. It's just not because the person was in a better shape on that day. So significant improvement in walking speed, stride length, perception of the performance after 6 weeks. In other words, personal satisfaction. So after 6 weeks, as I said, they also improved all that. Over the long term, improvements are maintained after 4 to 5 weeks after the end. So that's what we said. Improvements were maintained. If you really go through the intensive period, you can take a break and then resume your exercises later on. So improvements are maintained, as well as the Part 3 UPDRS, motor evolution. How come a treadmill works for the Parkinson patients? Well, as we've seen, walking on a treadmill improves walking, mobility, and quality of life. So actually, the more stable gait, the people has really to go along with the speed of the treadmill. However, you cannot stop in the middle, just wander around and stop walking. You have to keep walking with the treadmill at the same speed. We also can say that stimulation of the treadmill to your feet allows you to improve your gait. The author's suggestion is that well, those are in charge of the physiotherapy. So conventional physiotherapy plus treadmill at least 3 times a week for 20 to 30 minutes each. Before, in the past, we wouldn't use treadmill. We were scared. We were scared that the people would fall off the treadmill, etc. Whereas now it's been proved that it would be a good thing to add this to the conventional physiotherapy. So we say we do not really know what really improves walking within among the different patients, but we can say that the stimulation of the running element triggers something within the brain, like walking parameters close to the normality. So the brain really is working at some parts that are not really impacted or affected by the disease. Then it reduces visual distractions, increases the concentration, hence the exercise is more efficient. Also, it provides an extra rhythm. It forces gradual adaptation to greater demand. Obviously, from time to time, you increase the speed, hence you increase the effort. And by walking and gripping the handlebar, it improves the balance, and you will not get fall off the treadmill. And then the bicycle. So the idea of the bicycle is that it's a capacity that is maintained. As you know, you learn to ride a bike when you are young, and even though for 10 years you won't be riding it anymore, 10 years later you'll be able to use it again. So whenever you have Parkinson, automatic things are hard. Why? Bicycle is helping you, maybe because of the pedals. The fact that you have to ride the bike and the legs are running, that's maybe why the brain is being stimulated by the movement. So maybe that's why it works out. So now, walk or cycle. You can say, well, I cannot do both bicycle and treadmill. If you want to choose, there are some commonalities. So similar stimulation of the nerves in the legs in the same fashion, whatever the exercise you choose. And then the same fine motor adjustment and anticipatory postural adjustment. Because if you do not walk in an appropriate fashion, you may lose your balance. It's the same with the bicycle. So only anticipatory adjustment. You already know what you have to do with one leg while the other one is moving. So those are the similar elements or commonalities. Differences. Coordination appears to be easier when cycling as compared to treadmills. There is also less MEC for cycling. So, for instance, somebody with arthrosis or with pain in the feet, it's easier to walk on the treadmill than use the cycle. So also you have a more lateral stability required while cycling. And usually people with Parkinson, they really have a balance, they have less lateral balance. So it depends on your condition. You may choose between both. Boxing, we've already seen that. It's an excellent exercise. However, they did some 24 to 36 sessions of 90 minutes over 12 weeks. And the patients were able to keep on with 23 more sessions. So they would do boxing, stretching, strength work, and endurance. And the patients were assessed every now and then. So the result, all the 6 patients improved after 5 to 12 areas in boxing. That's really promising, and the improvements continued afterwards. So you may choose to do some intensive sessions, and then you can keep on. So as for the patients with mild cases, they improve significantly faster than the others in 12 weeks, especially in walking. But patients with moderate cases still improved, but it took longer, obviously. So how come boxing works? So because it engages the whole body. So the lower and upper legs and arms. So you can do only one exercise and it can help everything. You have very fast movements in all directions. Balance is really involved throughout the whole boxing exercise. So there are no research right now as to what sport is better than the other one, but we know that it's very good. And complex sports where you require strength exercises and movement exercises, faster exercises, are better than only moving your legs up and down 1,000 times a day. It's not as useful. So you've seen that in the stand. The whole program is explained. So we do provide boxing and other adapted sports for Parkinson's patients. There are other new sports that were developed through computers. So those are UPDR. So we had two different groups of patients, and we really noticed a strong improvement regarding at the scale level. So there was an improvement for rigidity, for tremors, less tremors, and bradykinesia. So forcing is like with a bicycle, like on the picture, a person is pedaling, rotating the pedals, and you have an equipment that makes you really concentrate on your effort. So for instance, you have a target to reach, maybe there is some specific speed to maintain, and if the person slows down or even stops, then the machine is going to restart the whole movement. Sometimes the person, for any kind of reason, she's distracted, she doesn't have that much energy, or is in an off period, so the bicycle is going to resume the speed automatically. So the person can recover the strength of the effort. So the idea came from a tandem. So a physician who had somebody suffering from Parkinson's in his family, and he went with this bike. And after some time, the Parkinson person was able to move a lot better. So it was a really finding, leading that this assisted forced repetition was helpful. Nowadays, you have more advanced equipment that really allows you to do that, but it can help you discover this capacity. Here I've also added, well, that's a website where you can find very different exercises focusing on Parkinson, very easy ones that you can do at home. There is a whole list, a whole range of exercises. You can print that and keep that at home. Now we're going to talk at a more advanced level. Whenever are you going to turn to a physiotherapist? For sometimes you didn't need any, you didn't have to show up in a hospital, as we said earlier on. You have to wait for quite a long time. When is it ideal to go to see the physiotherapist? Usually the neurologist or the physician is going to ask the patients to turn to the physiotherapist whenever they reach stage 3. So as soon as they start falling down, because doing exercise by oneself is no longer enough. You have to go get some more specialized help. So whenever you do not have any issues with falling, you can do exercise by yourself. Afterwards, it's more tricky. So that's a promising pattern of a physiotherapy treatment approach. It's not a reality within our hospitals yet. So the actual pattern is that the physician refers somebody with Parkinson to physiotherapy after an acute event, so a fall, some pain, an accident that has an impact on the physical condition. Whenever you show up at the hospital, you cannot do physiotherapy for 6 months, so you have to wait for some time. Afterwards, you are being released because we have the people who are on the list waiting for the exercises. Usually we develop an exercise program. We know we all are willing to do some exercise, but at some time, after a few weeks, we have something else to do. Today it's nice, I'm gonna go out, but tomorrow it's gonna rain, I won't be out. Whether you have Parkinson or not, it's always the same pattern. You abandon your exercises and there is no follow-up. So whenever we see somebody who doesn't go to the physiotherapy, when the person stops doing the exercise, there is no follow-up, and we don't know what the person is going to do after 1 month or 1 year. So regarding, there is little consistency with exercise. We've seen that. And what we do, we wait for the patient to have another accident to go back to hospital and restart the whole cycle. So it doesn't have an important impact to work this way. So as for the ideal approach, the new one, but it's rather an idealistic one. What I've seen is that in the US, in private centers, so for wealthy people, where a whole team really manages the patient and accompanies her over many years. So the Parkinson patient will be assessed at the onset of the diagnosis by an interdisciplinary team. So there is not only the neurologist, but also the whole team, like nurses, orthophonists, etc., all kind of therapists. So the onset is fine. Even here in Montreal, we have those teams. But then there should be a focus on prevention. So as I said, exercises we mentioned, should the neurologist doing the diagnostic state, look, you have to do some exercise, he will prescribe you some exercises and he's going to let you know where you can go for this kind of exercise. Then you have exercise program that have to be individualized. So for each person who has a different issue, even though it's the same disease, the exercise program may change. So we also have strategies built around the patient and education of the caretakers. So you have to focus on, well, usually the hospitals say they don't have the funds. So the patient really has to be at the core of the whole team. And we also should have a regular follow-up and reassessment. Just for instance, we've been doing an exercise program with this patient. Either it became too easy or the person abandoned that. So periodically or regularly, we should update it. That's the ideal situation. We are at the beginning of the program. We haven't reached the exercise level yet. So now, is physiotherapy effective for Parkinson? I'm going to say yes. However, research findings are quite new in this. So back in 2001, they gathered all articles describing exercise and Parkinson. There were only 280 studies at that time, and they looked at the physiotherapy, and there was insufficient evidence to support or refute the efficiency of physiotherapy. Luckily enough, they did the same study in 2012. And they picked up all the different research done since 2001. So the number of studies was quite larger, 1,518, as you see. And they checked the efficiency of the physiotherapy versus not doing anything. And they noticed that there were significant improvement in speed and endurance, in walking, the stride length, balance, and all the different measurements. So finally, it was the first time that it was proven that physiotherapy and exercise were efficient. So nowadays, yes, indeed, I've seen some neurologists sending Parkinson patients quite fast, without waiting for any incident or accident, to do some exercise. The objectives of rehab, well, there is the diagnostic and the onset. From then on, you should focus on the more preventive interventions, because at that time there are minimum issues. You can do anything. There is just a label on your head of Parkinson, but you do not have yet a very severe issue. And then at stage 2 to 4 on this scale, you really have to set some objectives, some targets, improve all the different activities, the transfer, posture, position, whatever that can be affected by the pathology, balance, etc. When really you are at the late phase, you can add exercise or intervention, but the target may change. You have to be more realistic. If somebody has been having Parkinson's for 20 years, well, maybe he will not be able to run. So what's the issue we have in physiotherapy?
Because it happens when it's more advanced, we cannot get them to work intensively. So we do exercise, we can do treadmill, we can do stationary bike, but if we cannot have the intensity and the length, that is enough to have an impact on the pathology. Because sometimes, apart from Parkinson's, there can be other health problems. Could be diabetes, could be other issues, stroke or other things, so that cannot exercise as you did before. Also, we said this already, we always have to encourage the person to do the maximum. So here we do the maximum. There's improvements, of course. So the our role is to improve mobility, walking, and balance. And the program, as we said, individually as much as possible. So physiotherapist does these exercises, autonomy, security, when things are going downhill. So when it always becomes difficult to move because we cannot work with automatic movement. So everything we do without thinking becomes blocked by the pathology. So we have to think about every individual movement. But if you have a good way to move, you can move almost normally, and that's what I'm going to show you. So the strategy is to say we are going to circumvent these areas in the brain that are ill. We're going to short circuit it. We're going to work in other areas, work in a different way. So what are we going to do? We're going to get the zones of the brain where voluntary movement exists. And so if we say, okay, now I want to go touch this screen, it's not an automatic movement. My brain will give the command to my arm, etc. So that's the way how even with Parkinson's we can do things that we didn't think we could just by wanting to do it and commanding our body and responding to certain stimuli. So the strategies to really be able to move better is visualization. So imagine here in your head how I'm going to get up off of a chair, how am I going to go down the stairs, etc. So you think about it. I'll use the ramp and I'll put one foot in front of the other, etc. Repetition of the movement. For example, a patient that cannot get out of the wheelchair, we get her to repeat the movement. The first thing is to put the hands on the arms, then lean forward, then push with your legs, etc. We repeat these movements not because we want them to become automatic, because then we just get back into the same problems. But if we say, okay, first step, and then put your arms, and second step, lean forward, and then so that one step gives rise to the other one, so that it's a process and so that you do it voluntarily and not automatically. You have to you should not give them two things to do at once. Too much information and these brain will block. If we just say stand up, that is possible. Go to the door. If we separate the tasks into smaller tasks and we do them one after the other, it is much easier. Sometimes if things are not going well, we can give hints. We could put X's where you're supposed to put the arms. You can put a red piece of tape under the walker to show where you have to lean towards. And so to repeat and do it baby steps. And so there are techniques that exist for that. And usage of cues, visual cues, external indices. These are cues that give rise to movement. For example, it can be right, left, right, left. It communicates with parts of the brain that are not affected. It's easier to walk by saying left, right, instead of trying to force the leg to move and it won't. So with these cues, the information goes through the zones that are not affected by the illness. Can be music, could be a rhythm. Have some headphones with some music, gives us the rhythm for walking, for example. So also when there's blockage, this is when you are blocked and cannot move, there are strategies for that as well. We can say, okay, 1, 2, 3, go, and the movement starts voluntarily. And if we try to force and get anxious, and it blocks even more. So when you don't think about it, you just say 1, 2, 3, go, and let's move, and the movement happens. And so it could be visual cues as well. So to amplify the movement, it's a cane with a laser. So there's a cane here that has a laser light that projects a line on the floor. And the idea here is to not walk. Really, you just want to try and step on the line, and it forces the brain to work through areas that are not affected by the illness. We also have all kinds of walkers with visual cues, indices. There's a scarf there, a piece of tape. So when we have difficulties moving forward and there's sudden blockages, it's not the walking that you have to think about. Okay, let's take a breath, and then with my knee, I'm going to touch that red piece of fabric. And so it's a way to move forward, and we try to hit the piece of cloth with our knee, and we start walking again. There's also a laser that you can put there to have a line on the floor. You just try to step on the line, and the brain will start movements again. Or this walker, I don't know if you know it. It's the best walker on the market. It has lasers that are integrated. There's a rhythm there as well. Generates rhythm to allow you to facilitate movement. So in conclusion, it's really important to move as much as possible and to start moving as quickly as possible. And at all levels, you should not give up. There are always ways to move despite the constraints of the illness and everyday problems. Thank you. Are there any questions?
On the effect of lymphatic drainage massage. Pouvez-vous, s'il vous plaît, commenter sur l'effet de...
Can you comment on lymphatic drainage massage? I don't have any experience with lymphatic drainage massage. I know about lymphatic drainage massage. In my opinion, it could be beneficial, but I cannot tell you what the impact would be on the illness itself. I think that it can be beneficial. Anything you can do to get circulation going can help. To get moving can help. I've heard stuff about it, but I've never seen any specific correlations between lymphatic drainage massage and Parkinson's. I'm going to go and get some information on that. Thank you. This is inaudible for the interpreter.
Thank you. You were talking about the treatment of the deep brain stimulation. Were you saying that if medication is stopped, not doing as much good as it was, is one of the reasons of having it?
Non, 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 pas du tout.
Not at all. Deep brain stimulation, not at all. Deep brain stimulation is used for certain motricity issues that are more specific. For example, a person that has a lot of tremors but doesn't have a lot of other problems, just tremors, and for which we have to give a lot of medication, and the person is still relatively young. So giving the medication early or in bigger doses, we will see the complications, the secondary effects of the medication. So we want to avoid the medication producing more problems than the symptoms. But we cannot say that they are interchangeable or one replaces the other. It's only under certain conditions stimulation can help, and by doing that, we can say we have a certain lapse of time, a few years. We're lucky where the medication is reduced or even stopped. So we give ourselves a chance that the medication will have an effect for a longer period of time. We're pushing back the medication, and the medication will be effective for longer, but it doesn't replace medication. Thank you. You're welcome.
For your beautiful presentation. At the beginning of your presentation, you mentioned that some of the recommendations were to do exercise for a period of 6 to 8 weeks or 8 to 10 weeks. Would it not be recommended? I'm not sure why that is. Would it not be recommended that this is a lifestyle change?
Yeah. Non, ce que j'ai montré, c'est comme les résultats.
I showed was the results of research, and so it's different. The reality of research is to prove if a technique is good or not. Like treadmills or bikes, we did 6 weeks and it's good. There's a certain improvement. They stopped for a certain period of time. The improvement is maintained, and that proves that treadmills are good for Parkinson's. But as a person suffering from Parkinson's, you should not stop. I'm going on vacation for a month. Well, what am I going to do with my exercise? Well, it's not the end of the world. I can stop for a month, have a vacation, do something else, and when you come back, you start again. But ideally, you would want to continue and never stop. Sometimes you don't feel well for a day or two, or you have no energy, or you have a cold or whatever, and you stop. That's fine. But you have to start again as soon as possible and not stop as much as possible. So these recipes that I'm giving you, that's how the research shows something is good, is when we keep doing it and we can observe it. And the reality is we have to never, ever stop. You said earlier that when the illness is more advanced, then you need to teach people how to sequence movements, the sequence of movements. Wouldn't it be useful in the beginning of the illness to teach them how to sequence their movements, and when their illness will be more advanced, they will be masters of that? Yes, that is what we want to do. It's the way of teaching it that's different. In the beginning, on the outset of this, we say, if we want to do Tai Chi, sequences of movement, boxing also is sequencing movements. These are complex activities. The sequencing of movement is there, but we do it more naturally, if you will. Whereas when the illness is more advanced, the sequencing must really be shorter and step by step. But it's the same principle. It's the exact same principle. The more sequences we learn, the longer and complex they are, the more we can learn these movements, so that if the illness progresses to the point where it affects these movements, we know how to do them. You're absolutely right.
A walker that's excellent with laser and movement. So first I want to know the name of it. And I also want to know if it's good for people who have that problem when they start to walk backwards. Is it retropulsion or something like that?
Je vais vous montrer. Donc, c'est celle-là.
The walker is called U-Step. You can find it in Montreal. It is at André Viget Sport. It is a sports equipment store for medical. They have medical supplies and prosthesis. They have the exclusive distribution. It's an American product. It's a very stable and sturdy walker. It has 5 or 6 wheels. It is very strong. It is has double wheels in the front. In the back is to stop the walker from falling backwards. There's another one in front to go up curbs for going on the sidewalk. There's laser as well, and there's also a metronome that gives you the rhythm that you can follow for walking. So it's very expensive, however. I think it's about $1,000 for this walker. So it's not something easily affordable, but we use it, especially for training with the lasers and the metronome. Then we can adapt it to regular walkers or even ordinary walkers that only have 2 wheels. You can see here this thing that's here is a laser, the one that we bought at the Renault Depot to do the lines on the walls. It's a laser that you can buy at the hardware store with Velcro. You put it on the walker and it does the same thing. So there are beautiful solutions that are more expensive, but there are solutions you can do for cheaper. You can buy that laser sight at a hardware store for $20, for example.
I would like to know, I have terrible problems with my feet, and the feet get cold, and I think sometimes it's circulation, and sometimes it goes into the calf, but it's an everyday problem with my feet, and I've been to many podiatrists, and I have little aids, but it's a constant problem. Why do I keep getting this problem? I'm exercised every single day for 1 hour to 1 hour and a half for years.
Alors, vous faites déjà beaucoup d'exercices.
You're already doing a lot of exercise. I cannot say, but it is possible that there might be circulatory problems due to diabetes or things like that.
Me don't do anything. It's years. I go to the podiatrist maybe 10, 15 times. I have little moles that help, but I'm always in pain every day, every night.
Est-ce que ça ressemble comme des spasmes?
Is it like a spasm? Is it a spasm kind of pain? Is it a spastic kind of movement? Is it? It's a contraction.
Straight, then it's no good on my calf. What
Il
is that
faudrait
part?
évaluer. Je peux pas vous dire.
To evaluate, I just can't give you an answer like that. We will have to do an exam to see if it's a muscular spasm or if it's the muscle tone that is altered. We have to look at that. Sometimes, yes, it is related to Parkinson. We call it dystonia. It exists. It's like a cramp. Even if you do exercise, it is painful. Dystonia is what it's called, dystonia spasms.